Hi, welcome back to the channel. My name is Molly and today at Live UTI Free, we're chatting with Dr. David Kaufman about recurrent and chronic UTI testing methods. If you're new to our channel, be sure to check out the description below as we linked other resources that you might find helpful. Lastly, if you enjoyed these videos, think they're important and want to support what we do, be sure to hit subscribe and tick the bell so you get notified when we post new videos. And other than that, we hope these videos provide the insights you need to take the next step on your UTI recovery journey. Welcome, Dr. David Kaufman, and thank you for taking the time to join this Clinician Insights series in recurrent UTIs.
Thank you, Molly. Good morning to you.
Good morning. Firstly, for our listeners, would you like to tell us a little bit about yourself, perhaps including how you got into the role and where you're based?
Sure. So my name is David Kaufman. I'm a urologist in New York City. I trained in urology at Columbia in New York and have really never left New York. I practiced first in one of the big hospital systems here, and then went into a private practice, a solo private practice, where I practiced urology for about 25 years. And more recently, I've been involved in a multi-specialty group where I am the chief urologist. The group is known as Maiden Lane Medical. We have about 7 sites in New York City and the immediate environment. A big part of my practice is taking care of men and women with urinary tract infections.
Great. And how long have you been working with recurrent UTIs patients?
Well, that's an interesting story. I actually first trained in urology, and then I fellowshipped in male infertility. So your listeners and viewers might be wondering how I got involved in this field. Well, the way it works in the States is when you come on to a new practice, which I did when I finished my residency. I worked for a hospital system. You kind of take care of all the patients that nobody else in the urology practice was really interested in. And I was referred a young woman who had terrible urinary symptoms. Her life was in shambles. Her boyfriend dumped her. Her job fired her, and we really didn't understand what was going on. And to make a long story short, I eventually diagnosed her with interstitial cystitis, and that put me in the world of IC at the very beginning. This was 1990, perhaps. And we didn't know a lot about interstitial cystitis back then. We know a lot more about it now. And we know that there's a very direct connection between IC and chronic urinary tract infections. And just to kind of jump to the chase, I think most of us who have been working with IC patients over the past 25, 30 years recognize that whereas in the past we thought that those patients were for many years misdiagnosed with chronic urinary tract infections, and as a result the true diagnosis of interstitial cystitis was missed. In fact, we're now realizing that they did have chronic urinary tract infections, and many of us believe that it is the chronic urinary tract infection that eventually causes the damage to the lining of the bladder that leads to interstitial cystitis, where the infection is no longer the issue, excuse me, but it's the deficient bladder lining that causes these very, very severe symptoms. But there's a very direct correlation between women who are not adequately treated for urinary tract infections and who may eventually develop interstitial cystitis years later. So that's how I got into the field of female pelvic pain. And that's how I became very aggressive in treating my chronic UTI patients with antibiotics because I knew that I would be preventing many of them from developing this much more awful condition known as interstitial cystitis, where there really isn't an easy fix for.
Yeah, no, that's really interesting. So to help provide our audience with some more details about your practice, what type of testing do you utilize when investigating recurrent UTIs, and in what situations would you do so?
Okay, so, I mean, I think that the vast majority of women who come to me are ones who just simply fail first-line therapy. They're treated by their PCP, they're treated by their gynecologist, they're sometimes treated in urgent care centers. And I don't know what happens in the UK, but typically patients are treated based on symptoms in these scenarios. They are, they give a good story for a UTI. They get a dipstick urine analysis at the time. If we're lucky, the facility sends their urine out for a urine culture, so we get a real true result in a few days, but more often than not, that doesn't even happen. They're treated empirically almost based on a urine analysis and symptoms. In this country, they're almost as a knee-jerk response, they're put on nitrofurantoin. The brand name is Macrobid, for 5 to 7 days. And admittedly, many of them get better and move on, but there's certainly a sizable minority who don't respond to nitrofurantoin. And perhaps it's that patient that eventually finds their way to my practice. A few words about nitrofurantoin. It's a lousy antibiotic. I mean, it's not a bactericidal antibiotic. It doesn't kill bacteria. It's a bacteriostatic. It kind of wounds it. It's the antibiotic of choice in these types of facilities because very few people are allergic to it, so they don't have to deal with allergic reactions. Very few bacteria are truly resistant to it, so it's kind of an easy antibiotic to use. And again, it probably works in a majority of cases, except when it doesn't. So I'll see those failures in my practice. If they're not absolutely miserable, I prefer not to treat them with antibiotics until I get the results of a regular culture and sensitivity back. If they're absolutely miserable, I'll put them on something with the acknowledgement on their part that they might hear from me in 3 or 4 days, and I might change that antibiotic to something better. And again, that works out for most patients. We get a culture back, we confirm that the antibiotic that they're on was the best antibiotic, and they get in touch with me in 7 to 10 days if they're not feeling better, and most of them are feeling better, except for those who don't. And then that kind of brings us into the world of what patients don't really respond to that sort of average term therapy of 7 days of a decent and culture specific antibiotic. And typically those are patients who fall into the chronic UTI realm, where I will ask them, when you have been getting antibiotics in the past, at the end of the course of the antibiotic, do you feel 100% back to normal? And most of these women say, I definitely was feeling better, and I didn't feel like I needed to be treated anymore, but I really wasn't perfect. And that's how this chronic UTI issue begins. Mm-hmm. And once the bacteria kind of take hold to the lining of the bladder and into the mural wall of the bladder, it becomes a much different animal. In terms of treatment. A 5-day course or 7-day course of even the right antibiotic doesn't necessarily wipe it out, because these bacteria are embedded into the wall of the bladder. And, it's partially the fault of the patient that they really didn't jump on it, and they accepted, partial treatment and better but not perfect kinds of symptoms. And it's partially the fault of the doctor, who typically treated them with an antibiotic that wasn't culture specific. They felt better from it, but they weren't really cured of the infection. And these symptoms typically stretch for months and months and months by the time I see them. And the unfortunate thing is that at that point, when we do cultures on them, the cultures are typically either negative or low colony count, right? Less than 10K bacteria. Your viewers aren't going to like hearing this, but I do try to convince the patient to allow me to do a catheterized urine sample. It's not the most comfortable experience, but urologists who take care of patients like this, we're really good at it, and we know how to make patients feel as comfortable as possible. And the test we're talking about, a catheterization that takes under 30 seconds to do. But the advantage of that, it's a huge advantage, is that we don't have to worry about bacteria on the labia of the vagina and in the vaginal vault contaminating the urine sample. So that when I get a less than 10K bacteria on a catheterized sample, we both know, the patient and I both know, that this is a real infection that's in the bladder and probably represents a embedded low-grade smoldering urinary tract infection that needs to be treated aggressively. And we'll talk about that later, I guess. The problem is that we don't typically get sensitivities on these low colony count bacteria because, it just can't be done practically. There's not enough bacteria to really tell us which antibiotic works better than another. So then we're kind of winging it a little bit. And that's really how I practiced and treated patients in this situation for up until about 5 years ago. And you probably know, Molly, that there's been a seismic shift in our testing capability over about the past 5 years. First, it began with DNA PCR work, which was a dramatic improvement over cultures, because we were able to identify maybe 70% of the DNA of bacteria. So we were able to identify the specific bacteria 70 or so percent of the time. And we were able to find resistance genes in these genomes of the bacteria. So we didn't know which antibiotics worked, but we had a historical perspective on that. But we did know which antibiotics we shouldn't choose to work. And then that eventually evolved shortly afterwards with NGS testing, which, are you guys familiar with that in the UK? Yeah. So that stands for next generation sequencing. And that looked at the 16S ribosomal RNA, which of the bacteria, which we had a very good library on identifying the RNA of different bacteria on the 16S ribosome. So our identification capability improved to about 98.5%. And we still had the advantage of having resistance genes. So that's kind of where I am right now. I don't do this on everybody, to make it clear. I do this on people who have that history of chronic cystitis, who've been on short-term antibiotics, and who have failed that, who don't feel completely better. And I will tell your viewers that it's worthless, almost worthless, to do an NGS PCR study on a voided sample, because it's going to pick up everything. And if it's a voided sample, there is going to be contaminating bacteria that wasn't even picked up on the regular culture. It's going to be picked up by the NGS markers. So, I can't convince everybody to let me catheterize them, but it's almost a waste of their money, because most insurances, at least in America, don't pay for this, although it's not terribly expensive. And I just hate for my patients to wait their money and end up getting like, 8 different bacteria that show up, and that just muddy the waters. It just confuses the issue. So I do try to convince them to allow me to catheterize them. So then we do know that every bacteria that's being identified is coming from bladder urine. I'll also send, you only really need to send a small amount of urine for this PCR NGS testing. So the remainder of the catheterized sample, I send for regular culture and sensitivity. We get those results back in about 4 or 5 days. Usually they're negative. That's why we're doing this other test. We get the PCR test back in about 5 days, and we get the NGS test back in about 10 days. So, these are patients who typically aren't miserable. They're just, uncomfortable, and we're usually able to just wait until we get all that data in, and then we can make a really good educated choice on what antibiotic to put them on. But there's one more facet to this treatment regimen that's really, really important. At this point, and I'm sure most of your viewers recognize this, at this point, 5 days of antibiotics, 7 days of antibiotics, 10 days of antibiotics just ain't going to cut it. Patients don't get better from that. And so, at a minimum, I'll treat for 3 weeks, see them again in 3 weeks. And if they're not perfect, and there's one other thing I want to go back to, if they're not perfect, treat them for another 3 weeks. So when I said in the past on this broadcast that I was aggressive with antibiotics, that's what I mean by being aggressive. If they don't feel a big difference in 3 weeks, a lot of doctors might just quit and go on to something else, or maybe treat them for interstitial cystitis, which is going totally down the wrong path. You need to kind of hang in there as a physician and just keep on going, because invariably, the majority of patients, by the time you're on the second round of antibiotics, do start feeling better and can be made 100% better. The one thing I wanted to go back to, and I'm sure that you have questions for me that would have asked me these questions, but since I'm on a roll right now, let me just address that. Physical examination, really important. I will not treat a woman with a chronic UTI without examining them first. And really what my goal is in the exam is to make sure that nothing else is going on that could be causing similar and overlapping symptoms. So the exam takes all of 3 minutes. It's not a big deal. I don't use a speculum in the exam. What I start with is what is known as the Q-tip test. I don't know if that's something that you're familiar with, but the Q-tip test just takes a long applicator stick with a little cotton ball at the end of it, and I gently stroke the inner labia of the vagina. And what I'm looking for is severe sensitivity that we associate with the condition known as vulvodynia. And vulvodynia is not a urinary tract infection. And patients with vulvodynia present with urethral burning. They think it's urethral burning that they're experiencing. But it's not. It's the tissue around the urethra, and it's the tissue along the inner labia that's exquisitely sensitized for a whole lot of reasons that we don't have to get into right now. But to treat these patients with antibiotics is just an exercise in futility. You need to do the exam. You need to find out if they have vulvodynia, and you need to treat that with its own course of therapy, which we don't have to go into right now because this is a UTI talk. But that's very important. But we don't put the Q-tip down yet. Then we find where the urethra is, and on either side of the urethra are 2 glands, which are known by many names. One of them is the vestibular glands. And what I do is I gently push into those glands on either side. And if the patient reacts to that, and they say, oh yeah, that's where my pain is, again, presenting with urethral burning, not, they have vulvar vestibulitis. Again, a condition that's not going to get better with antibiotics. And they'll tell me that. I've never felt better from antibiotics. I still have urethral burning. What's going on? So, you know, the buck kind of stops in my office, that I'm often the first one that's ever even recognized that this is a possible diagnosis for these patients. And again, it's treated totally differently, which is another talk. So we're not finished with the exam. The next part of the exam is I put the Q-tip down and I put my gloved finger, my lubricated gloved finger, into the vagina, and I gently, can you see my fingers in this picture? There you go. So I gently lift up, there we go. I lift up on the floor of the bladder. And if, you know, patients with chronic cystitis will go, oh yeah, doctor, that's really uncomfortable. That's what I feel. And that kind of reinforces the diagnosis that's made based on just history. That's almost always present. If that sensitivity ain't there, they don't have chronic cystitis, and there's something else going on. Of course, if they react to that finger lift by screaming and jumping off the table, that's not chronic cystitis either. That's most likely interstitial cystitis. It's a logarithmically greater sensitivity than what we see with embedded urinary tract infections. All right, but our fingers are still on the vagina. We're still not finished in there. Next thing we do, and this is probably the most important thing, is we swing our fingers laterally and we push up against the levator ani muscles and the pubococcygeal muscles on either side, because sometimes it's only on one side or the other side. Most of the time, it's on both sides. And of course, if they have real tightness of those muscles, and it's uncomfortable when I do that, you know, they definitely have pelvic floor dysfunction, right? Or pelvic floor hypertonic spasticity, right? That's not going to go away unless it's addressed specifically with pelvic floor physical therapy. Is that something that's happening in the UK these days?
Yeah.
Okay, crucially important. What were you going to say, Molly?
I was going to say it's just so interesting how the conditions can overlap. Like like the conditions you're talking about, the symptoms, how they overlap between each other, and making sure that you do receive the right diagnosis to treat the specific condition.
Otherwise, you're spinning your wheels for months.
Yeah.
Right? Spinning your wheels for months. So here's the kicker, though, is that you can have, not only are they overlapping conditions, but they're also potentially concurrent conditions, where you can have vulvodynia and vulvar vestibulitis. You almost always have pelvic floor dysfunction. And let me make this important point. Pelvic floor dysfunction, pelvic floor muscle spasticity, causes urinary symptoms. It causes urgency. It causes a frequent need to void. It causes what patients interpret as bladder spasms, but they're not bladder spasms. They're pelvic floor muscle spasms. So that's why it's perfectly common for a woman to present to me with symptoms that sound like chronic cystitis or even a urinary tract infection, where they don't have it. They don't have bacteria, even with NGS testing or PCR testing. And what they have is urethral burning from the vulvar vestibulitis and the vulvodynia, and urinary urgency and frequency from the pelvic floor spasticity. So antibiotics are not the approach here. We have to address those two conditions individually. What makes matters even more complicated is somebody could have chronic cystitis with pelvic muscle spasticity, because it's all about the upregulation of the nerves that go to the bladder and the vagina. And when those nerves are irritated for a long time, as they are with chronic cystitis, and as they are with vulvodynia and vulvar vestibulitis, it will cause this wind-up phenomena of these peripheral nerves that feed back to the nerve roots at the S3 and S4 spinal area of the spinal cord, which also share nerves that go to the pelvic floor muscles. So that wind-up phenomena is transferred over to the nerves that go to the pelvic floor and cause the pelvic floor to go into spasm. So if patients have either of these primary conditions of chronic cystitis or vulvar vestibulitis or vulvodynia, they will often develop over time, after a few months, this pelvic floor muscle spasticity. So even with treating with antibiotics properly of chronic cystitis, patients still might not feel better because the pelvic floor hasn't been addressed. So it's complicated. You need to take your time with these patients. You need to do a physical exam every time they come in, because often at the 3-week mark, when you do that bladder, they'll still have similar symptoms, but when you do that bladder lift exam, it'll be remarkably improved over it was when they first came in. But if you haven't addressed or recognized the pelvic floor dysfunction, that's still there and giving these patients the same symptoms. So as I said before, it's complicated, and it's not as easy as taking out your prescription pad and writing out a prescription for antibiotics for these patients. All right, I'll let you ask another question, Molly.
One I was going to ask is, we often have patients experiencing negative UTI test results. So what advice would you give to someone who suspects that they have a UTI but are testing negative using standard testing methods?
Yeah, so I think we've really covered that, but it's important enough to talk about it again. They need to be examined properly to make sure that even though they have urinary tract symptoms, that it is not something else that we just spoke about. And then, of course, you know what I'm going to say. I think they need to be catheterized and have a sample sent for a catheterized culture and sensitivity, but also if they're up for it and they're willing to pay out of pocket for the NGS and the PCR testing, and that's the right move.
Yeah, no, that's a really good summary. So how can recurrent and chronic UTI patients reach out to your practice?
Well, I have a website, Maiden Lane Medical. They can just Google Maiden Lane Medical and find me as one of the practitioners there and make an appointment just online. It's really very easy to just fill out a form and make an appointment online, and one of our receptionists will get in touch with you. If you're in the States, our phone number in New York, our trunk line number is area code 646-290-9560. But online is really easy. We've got a great staff of receptionists who will get back to them. And it really doesn't take that long to get to see me. I see a lot of patients every day, and so they should really be able to get in a week or 2 weeks probably.
Okay, amazing. Well, thank you for providing insights into the testing and treatment methods for use of chronic and recurrent UTIs. We will link down your practice below in the description if anyone is interested. But thank you very much for joining this talk.
You bet, Molly. Thank you.
Thank you. Thanks so much for watching. I hope you found this video helpful. You're always welcome to reach out to us for more information about clinicians who specialise in recurrent and chronic UTI. Our contact is in the description below. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveUTI3.com for other articles on recurrent UTI treatment options. Of course, if you like what we're doing on this channel, make sure to hit the subscribe button here on YouTube and tick the bell so you get notifications about future videos. Thanks so much for joining our Clinician Insight series. If you have suggestions for who we should interview next, be sure to drop us a comment.